I want to add my thanks as well, ladies, for being here, for all of you for coming today, and thank you for your service. I've worked a little bit with military sexual assault, and I'm wondering, I guess to anybody on the panel, but to Dr. Hayes, it seems that when we really, just a couple of years ago, started really working together on solutions for this unbelievable amount of military sexual assault. And I also serve on the Armed Services Committee, which I really became kind of my attention there, and many of us have been involved with that nationwide. So do you see long-term, it seems like right now we've got a lot of military sexual assault women coordinators in a lot of facilities now in the VA, and especially the larger ones. Some of the CBOCs, even in my area, have service coordinators as well. That seems to have tied up so many of these loose ends about coordination of care, about the vulnerability of feeling like nobody's following up. When you look at the kind of issues that Ms. Haffiker described, when the VA looks at the model for success for being able to treat female veterans, is the MST kind of a model of what you're following as you're kind of putting these building blocks together to deal with more women coming in and be able to treat them adequately and with first-class health care?
Absolutely. I appreciate the fact that the MST points of contacts have really shown a way to coordinate care within our system. And I'd actually like to talk to Dr. McCutcheon a little bit about some of those points in terms of what we've learned.
Thank you, Dr. Hayes, and thank you for your recognition of the MST coordinator. Yes, we do have an MST coordinator at every facility across the country, and as you mentioned, in some CBOCs, we also have MST coordinators. However, I think that although it's a wonderful infrastructure for us, and we have been taking care of those veterans who have experienced MST, and more veterans are actually seeking treatment who have screened positive in our system. So we see that as good news. It is a collateral position. And some of the positions that Dr. Hayes has spoken about are actually full-time positions. And so there is a more dedication. If you know any of our MST coordinators, they're typically psychologists, social workers, and so they also have responsibilities as clinicians to provide mental health care. So the MST coordinator is an administrative position, but thank you for recognizing the coordination.
And I don't know if this question would be for you, Dr. Hutchinson or Dr. Hayes, but so as more women are coming into the military and more OBGYN services need to be available, more pregnancies identified, more women accessing that kind of help, what happens, for example, and I was just asking this question to my colleague, Dr. Winstrup, what happens when a woman becomes pregnant in the field somewhere? She's active duty, she becomes pregnant, she leaves, and are there specialists in the VA, as there are for the whole area of prosthetics? Walter Reed, one of the best places in the world that's become the prosthetic maker. What if these women are coming from areas of harm, toxicities, things that could be identified that could be harmful, passed on to a child? Is there anybody in the country that the VA looks at and says, if there's a question about what she was exposed to prior to this birth or even after this birth, where does she go? And is there, if that's not available in your area or you're in a rural area, what do you do? Who do you ask? And is that a fee-based service to a specialist somewhere, and who would that be?
Well, you ask excellent questions, because we have been very attuned to the issues about what are the effects of military service on women. And so there's a number of points in which this is critical. One is our whole department that does look at exposure issues and in the Office of Public Health, and we work very closely with them about whether any of these toxins could have a reproductive health effect. And for quite a few years now, we've looked at everything from depleted uranium to water to airborne issues. Mm-hmm. The other thing is, I have a OBGYN on my staff as Director of Reproductive Health, and we have consistently looked at how to get information to the field about how to evaluate the military experience. Where was this woman? The good news is, at this point in time, we do not see patterns of reproductive health effects from military service. That's a really important message. Mm-hmm. But we're not stopping the look. It continues to be an active issue for VA. If someone were to have a consideration about that possibility, we certainly would hook them up with a high-risk OB if we thought there was something going on.
I appreciate it. Thank you very much. And the Chair yields to Ms. Custer for 5 minutes.